Welcome to Community Health Network's first ever live stream of a colonoscopy. Colonoscopy is a safe, effective method of examining the lining of the colon to diagnose colon rectal problems and to perform biopsies and remove colon polyps. Most colonoscopies are done on an outpatient basis with minimal inconvenience and discomfort. Today, Dr. Shekar Narayanan, an MD Anderson Cancer Network certified physician, will be performing the procedure. Colonoscopy is routinely recommended to adults 50 years of age or older as part of a colorectal cancer screening program. Patients with a family history of colon or rectal cancer may have their colonoscopy at age 40. Our patient, Tammy Schwank, has a family history of colon cancer and hopes to promote regular colonoscopies to save lives. If caught early, colon cancer is very treatable, and many will live a normal lifespan. If you have questions for Dr. Narayanan, please tweet at Community's official Twitter @CHNW, and be sure to follow us for updates and future streaming events.
All right, well, thank everybody for joining us. So basically, what I do to begin is I will just do a quick rectal exam on her, or an exam of the anus, kind of just making sure I don't miss anything. We check the sides, check the front on a female, check the front on a male, and the back, just to make sure I don't feel anything in the anus. And then this is the scope that we're going to be using, and we'll pass that in and start looking. And the goal is we have anesthesia here, so she is sedated, so she's comfortable. You know, some of the myths in the past have been how uncomfortable it can be, and with technology improving and medications improving, we just have found it to be much more effective, and patients wake up much easier. So we're going to get started. First part is the rectal exam. And again, she's sedated for this, and we're just going to kind of move around, making sure we don't feel anything, such as masses or abnormal structures or anything that is of a concern.
Dr. Narayanan, what are some of the symptoms of colorectal cancer, and how would someone know if there's something they need to get checked out?
That's a good question, and honestly, the best answer is most of the time you don't. And that's where the whole idea of screening comes into, because actually most people at an early stage, they'll have no idea. Now, if you are symptomatic, the more common reasons, number one will be rectal bleeding. Number two will be kind of a change in bowel habits, either more constipated or diarrhea, lower abdominal pain, cramping, nausea, rectal pressure if there's something in the rectum. But all of those are not just specific to, that's a little hyperplastic polyp right there, to colon cancer. So really the screening part becomes the money. So that's why it's so important to talk to your primary care physician, your local gastroenterologist, whatever it may be, to make sure you get checked, because the majority of the time you're not going to pick it up. What I'm doing here is I'm just kind of starting into the rectal area. These are valves, so there's usually 3 valves in the rectum, 1, 2, and then I'm going to make a turn and there's 3. And we're just kind of going through the rectum right now. For prep is fair right now, we're suctioning some of the stool out. And there's variable techniques people can use. Some people suction more, some people push more. It's all how you're trained.
And one of the questions that we got tweeted in, Dr. Narayanan, is if you see a polyp growth, how can you tell if it looks suspicious or anything you should be concerned about?
A lot of it based on size, sometimes if it's more ulcerated, but typically polyps themselves, they all have varying degrees of malignant potential. So that's why they're generally all removed. So when we see polyps, we generally try to remove them. And there's different techniques. You can use a little biopsy where you just grab it. That's a little polyp, hot biopsy. So that is a small little polyp that you guys can see right there. So we're going to get rid of that. And sometimes we take them out going and coming back, but that's pretty small, so I could miss that coming back. So we can take them out in a variety of different ways, either through a biopsy or a snare. And then for bigger polyps, sometimes surgery, or oftentimes we try to refer them to people that have more advanced techniques. Our colleagues at Gastroenterology Care, through Dr. Hollander and Harrison and Chacha, they have some techniques of mucosally or removing them through a colonoscope that are quite advanced. So that's been great for patients. Or sometimes we do combined larger polyps with a scope and surgery. Again, trying to avoid surgery if we can, but sometimes we can't. But the most common ways will be the way I'm describing right now.
Patients for having.
Thanks.
Another tweeted question in that we just got was, how does the camera, or how are you able to use the camera to see sort of that 360-degree view of the...
Yeah. That's a superb question. It's actually a limitation. So really, I don't have 360. There are some cameras that are coming out that are getting to 310 and things like that, but I really don't have 360 open. My limitation is more maybe 270 at the close. 270 at the most. So that's a limitation, and we have to continuously take it. So that's burned away now. So we're continuously trying to improve that. And so there's a company that has a 3. That's a superb question. And it's a limitation. You know, we flex and turn the scope multiple ways. And some of it is all the anatomy. You know, has the patient had previous surgery? Sometimes males and females have different anatomy that makes it harder or easier. And so it is a limitation. The prep, how much does the colon turn and flip on themselves? Has a woman had a hysterectomy before? We find all these things. Have they had surgery before? All these things affect how the colonoscopy goes and how accurate it is. But the prep is probably the most important part of it. So I use a little bit of water sometimes just to kind of guide myself as you get little angles that you got to kind of work around.
Another question that we got was, does colon cancer always grow in the polyps found in the colon?
I would say that's the majority. So most people, if you develop a colon cancer, you are probably started off at a polyp at some time. There are some cancers that do not. If you have a history of inflammatory bowel disease, such as Crohn's or ulcerative colitis, you can bypass that stage. Some of the more familial cancers may present very early with this, basically something that grew pretty quick. But I'd say for the average public, it's basically going to be something that came from a polyp first. And again, that just comes back to getting yourself checked sooner rather than later. And so there's criteria for that. You can see I'm kind of working my way through, and there's some turns, and here we run into stool again. So it's just kind of deliberate. It's just, you know, colonoscopy is meant to be for people to, it's a benefit. And so people should get it done. And again, it isn't the level of it was before in terms of sedation and recovery and the preps, you know.
And so because of something that you just shared with us, there was another question that was tweeted in, is that are people who have colitis more at risk or more likely to develop colon cancer?
They are. So they have, depending on the longevity or how long they've had the symptoms, their risk profile goes up depending on over 10 years, 20 years, 30 years. So most of those people hopefully are following up with a physician or a gastroenterologist. That is, all right, so here's a negative, not to stop that question, but here's where we have a limitation. So that part of the prep is not ideal. So this part is going to be difficult. So we're going to sandblast this as best we can and try and get through. But this will be one of the reasons your physician may say, I need to bring you back because the prep was not ideal. Well, here's an issue. So I'm trying to get rid of as much of this as I can, and I'll blast it away and look. But this is a limitation of where the colonoscopy is. Sometimes we have to bring it back. And this wouldn't matter what technique you wanted your colon checked in, whether it's CAT scans or blood work. To look is still the ultimate idea. So going back to your question, yes, if you have Crohn's or colitis, you are at absolute increased risk of developing colon cancer. And that's why it's important that you get your colon checked. I need some flush. So as you see here, I got a little bit of stool stuck that I can't get off. She's just going to flush it away from. Thank you. And most of the time, flush again, for those Crohn's and colitis patients, your gastroenterologist, whoever's managing that, will be absolutely on top of that, saying you are there. So we're actually at the end. So this here is her cecum. So her prep didn't go there. And how do you know that? Well, normally I would give you some anatomic landmarks. Let's see if I can flip in to how you know. And that's one of the identifiers, is you always got to have what's called a cecal intubation, where you're either looking for this crow's feet or a Mercedes sign, the appendix, or I'm going to see if I can't. Flip into her small intestine or her ileum. So that's her ileum. Ah, I missed it. I just missed it.
Another question that we had that came in would be related to the idea of the frequency, because of what you just described about how important it is to have the proper preparation. How often should I get screened for colon cancer?
So the screening recommendation for the average public is going to be age 50, unless you're Afro-American, which then it's 45. Now that is just a general public. If you have family history, it is 10 years earlier than what their person was diagnosed for, or no later than 40. So this is the ileum. There. So this is how I know that I've made it all the way. There we go. So this is something you can just use as a marker, or sometimes you'll check that for people with Crohn's or colitis or things like that. And that's how you know that they have disease there. So yeah, so it's basically 10 years earlier than when you were, and then the family member was diagnosed, or no later than age 40. Why don't you give me some more power flush? See, the thing is, this is a preventable problem for most people if you can just get checked early. And that's why it's just so important to discuss, getting your colonoscopy with your primary care doctor, and, seeing your gastroenterologist or colorectal person to kind of work together.
Another question that we had was, as an MD Anderson certified physician in colon cancer care, what does that mean for Community Health Network and for the cancer patients that are treated at Community Health Network?
So it's actually, I was lucky enough that the network allowed me to be a part of this. MD Anderson is the #1 cancer hospital in the United States, 10 to 12 years, 9 to 11 years, whatever number you want to use. And it's their expertise, it's their protocols, it's their guidelines. Sorry about the view, we're just cleaning the scope a little bit. I got a little bit of a plug in there. And so what it does for us is that we are able to follow those treatment plans and guidelines, discuss with MD Anderson on cases that are ongoing every single time we discuss these different patients. And so you know that you are getting the best treatment guidelines, the best plan from both medical, radiation, surgery that exists in the United States. And there's something to be said for that. I feel very lucky to live in a place that has this now, and I feel even luckier that I'm able to participate and help people. More flush. So you can see this is really where we run into the most problems. Thanks, Kim. More flush, please. Because I'm going to try and clear this as much as I can, but there's going to be a point where I can't say there's not a small polyp in here somewhere. And being in Indianapolis, there really should be no reason to not get checked. In this northeast area, if you have again, as I mentioned, our colleagues at Gastroenterology Care on the south side, you have the excellent group of Indie Gastro, Drs. Arinian and Haynes. I mean, they have a lot of options. And we've been in the city since 1979. So, I mean, I know this part is a little boring for people, but I'm just trying to clear it. Thanks, Kim.
So another question related to this is to your point about how long that the colonoscopy procedure's been available.
Yeah.
We have a tweeted question about the difference between, or the, I guess how much better is colonoscopy procedure than the colorectal screening test where you put a small amount of the stool on a piece of paper and take it back to your drugstore?
Yes. So there's two different types, and the more common one that people are going to have at like a drugstore is what's called a Hemocult or an FOBT, which is detecting blood. Okay, so it's fairly sensitive on detecting blood. I believe the specificity is about 79%, if I'm not mistaken. But the specificity is incredibly low. You can have that thing being positive because you ate beets the day before. So it's not very specific. There's also a new test where it's measuring DNA cells, FIT, much more specific. But the thing you got to remember about all these tests, or even like people talk about specialized CAT scans, virtual colonoscopies, all these have sensitivity, specificities probably in the 80% region. But if anything is positive, you still end up at the colonoscopy point. So you're not benefiting yourself from not doing the colonoscopy. It's a good adjunct. It's good for follow-up. We use FIT testing afterwards to follow people, and I'm sure our gastroenterologists do also. But it is not to replace. So as you can see, I've wiped out the majority of this stool, thank goodness. I think I'm good, Kim.
The next question was, what are the wrinkles representing on the inside of what we're seeing in the picture?
So this is the inside lining of the colon. Okay. So as I said, as I wash this back off, I am now in the area of the cecum. I'm trying to show you guys the appendix, because that's where the appendix is going to live, right there. There's a little indentation right there. And so basically the wrinkles are the mucosa, the inner lining of the colon. And so everybody's is a little bit different. Some are more pronounced. So these are just little folds inside the colon. This big fat thing right here, that's where you know you're at the cecum. Sorry for the view's not great. And then as I did before, I got into that ileum. So my goal is to just get as much of a view as I can while she's here to satisfy her and myself that I've done the best job possible. But these little folds are just, they're not anything to be concerned about.
If someone has an immediate family member who had colon cancer and you're doing a colonoscopy for them, does the location of where they had their colon cancer indicative of where that family member might have their colon cancer?
The general answer is no, and I'll tell you there are hereditary cancers that are more predominant on the right. And so if your family member had that and you had also that thing, then you would be more at risk also. And family history is really important. I mean, that other question was really important about when to get checked. But in general, it just depends on if it's genetic or not. If it's not genetically driven, then the answer is no. And some people's preps are not like this. Some people have perfect, and other people are 10 times worse than this. And sometimes we'll just abort and say you have to come back the next day or the day after, because it doesn't do anybody any good to go through this without a quote clean bill. It didn't accomplish anything. And there's a lot of different preps. They're not like the old days where people always have to drink 8,000 liters of stuff. There's low volume preps. There's pill preps. So that should never again be a reason to not do it. But as you can see, I have a view, but I can't always see behind the folds. And that is a limitation. We accept that in our, as a society with manufacturing and gastroenterology, we're trying to improve that. I think what I would want everybody to get out of this more than anything else. It's just not that hard. It's just not that hard. You got to sacrifice a night before where you take something that doesn't taste good. I accept that. I've tried almost all the preps. I admit, they just don't taste that well. And then next day, get a ride, someone takes you, someone does this for you, and then you're good. And I think if it's the third leading cause, there's something to be said for being checked.
One of the other questions that we had gotten earlier was how is colon cancer treated in the event that someone does have it identified?
So basically, once you have identified that there is a problem in the colon that is biopsy proven, then there's a kind of a starting workup will be basically the most important part would be has it spread? And so the use of CAT scans and PET scans will be initiated by your surgeon or your oncologist or your gastroenterologist. Flush, please, Kim. Thanks. And that's kind of our starting point. Then the typical next step for colon cancer, and I distinguish colon cancer from rectal cancer because they're actually treated differently, will typically be surgery, where the lesion is removed. We typically do with cameras or what we call laparoscopic. And then depending on the final pathology, including how invasive is the lesion, were there any lymph nodes involved, then we always refer to our MD Anderson colleagues for oncological evaluation, and then they determine whether chemotherapy is needed. Radiation is almost never needed, not never, but almost never needed in colon cancer. It is much more frequently used in rectal cancer. So the starting point again is identification that there is a problem, CAT scans, and then typically surgery, and then a meeting with an oncologist afterwards. So in her, I probably won't wait the standard 10-year guidelines, just because the prep really was not what I would consider to be good or excellent. I would consider this to be fair at best, and so I would push her to the 5-year mark. There would be some that may agree or disagree, but I firmly believe that it has to be perfect to recommend that 10-year mark.
A tweeted question that just came in was, are men or women more likely to get colon cancer?
Depends on what you read, but generally I consider them to be fairly equal. There really is no specific difference. I would hope that over time that the screening guidelines go to 40-45. That is not medically based. It is somewhat opinionated, and through history as it's going in the Afro-American population for 45. That's the liver, by the way, where you see the blue hue. But they're basically, depending on, some will say men are a little bit higher, but my data suggests that it's a little bit more even than that. This part of the prep, she did a really good job. And the key is on the withdrawal. Some people have a firm timeline that you're supposed to withdraw at least till. I just kind of go back and forth. You may hear people talk about 6 minutes. I think it's just making sure you do a good job.
A question we just got in was, is there a difference in the blood supply to the colon in comparison to the small bowel? Because we can see that there are blood vessels there in the picture.
There is a different blood supply. There's a different artery that supplies, even the colon itself has different blood supplies. There's several. But the small intestine is supplied majority by one blood vessel. And then the colon has some of that same blood supply and then another blood vessel. It doesn't change much for us except anatomically when we operate. We just have to know where it is so we know what vessel to take. But these vascularities, because the small intestine really isn't able to be visualized like this so much. I mean, there's techniques where our gastroenterology colleagues can get into the small intestine through the stomach, or they do a camera test. They can see some of this, but you won't do this on a regular colonoscopy. You just can't get there. It's too far.
The question we just got to was, does smoking cause colon cancer?
I'm going to say it's at least a risk factor. Cause is a hard word to use, but I would say unequivocally, I firmly believe it is an absolute risk factor for almost all cancers. Obviously, people talk about lung being the most common, but I do believe that there is definitely some carcinogenic properties that affect the colon. There's people that talk about diet. It's very interesting. Colon cancer in the eastern part of the world is just not that common. But they see a lot more of gastric cancer in, let's say, Japan. We see a lot more colon cancer. We got to know that it's got to be a combination of environmental and diet. So I'm just kind of going back and forth. This was the part that had a little bit of more tricky problems earlier when the angle was tougher. So I'm just rechecking all this to make sure.
Question that we got though was kind of from, it looks like an informed viewer, what is a virtual colonoscopy?
So a virtual colonoscopy or a CT colonography are basically the same now. So basically what you do is you still have to prep, and basically there's a specialized CAT scan and they inject air through your colon and take pictures. It is a very useful test for us in two ways. We use it either if we cannot get through the colon based on anatomy or risk, scar tissue, you feel like you're going to cause a problem, or in someone very high risk where you do not want to sedate them or you think the risk of a colonoscopy is not outweighed by the benefit. Yes, is not outweighed. So there I use them. But again, the one thing to remember about those tests is if they come back showing something, you're still committed to having a colonoscopy. So, it's just important to kind of get yourself informed. I think that's what this is trying to do. It's just inform people of when to have it, why you should have it, who should you go see to have it, what are they looking for, what are your alternatives. My grandfather died of rectal cancer and my father-in-law passed away from colon cancer not too long ago. So I'm very passionate about this. And I know my gastroenterology colleagues here at Community or the ones on the south side are also the same, or anybody in the city. And everybody's passionate about what they're trying to do to help people. So I do a lot of this back and forth, just making sure I didn't miss anything on a fold.
Well, here's a pretty practical question that we got, Dr. Narayanan, which is a colon cancer screening or colonoscopy covered by Medicare or other insurance?
They are. They should be covered by every insurance. As long as you meet screening guidelines, which is age or family history, you are covered. And if you are not, I am sure that there are plenty of different groups that will come to your aid because it is absolutely covered by every insurance. How often you get is all dependent on what they find on their original colonoscopy, your family history, what your endoscopist felt of the colonoscopy prep, quality, angles, how well satisfied they were. But yes, it is covered based on the criteria that I mentioned. So a lot of it is how old are you, what is your family history, and then that's screening, and then there's diagnostic, which is, okay, Wyken. I'm having bleeding, I'm having change in bowel habits, I'm having pain. Those are differences. There's a workup and other less invasive things have been done to figure that out. Sorry, dear. So we're really almost done. We're almost at the end point. We started working our way. As again, I look both ways. Again, if I see a polyp that's pretty small or I'm not going to find it, I try and get it on my way in. Sometimes you'll find something else that's a little bit bigger and you know where it is and you can get it on the way out so you can do whatever you want to do with it if you really want to get all the way through, but you want to take your time.
We have a question that was related to something that you said a minute ago about whether or not, if there are differences between rectal cancer and colon cancer, can you have a polyp in the rectum area?
Yep. Yes, you can. So there should be, so that's where I took that polyp out before. So you can absolutely have a polyp in the rectum. The differences are only if it can't be removed, there's a little bit more options. So normally we would try and take a rectal polyp out the exact same way, using our standard techniques. If not, then they can either be removed through your anus through a surgery. We can use a microscope, or again, using a colonoscope through our gastroenterology colleagues. They can remove it with a special type of snare. So we have a lot of options for everything, and that's what you need. You just need physicians that are dedicated to learning the different techniques to minimize risk and minimize time off and still get a great benefit. But yes, you can have rectal polyps, and they are treated almost the same, except there's probably a few more options available to us without an operation.
Next question was, just in general, what are ways to manage your digestive health, your digestive system, things that you should do to keep your digestive system healthy?
Yeah, and that all depends on what your medical status is too. You know, the basic stuff is always going to either eat plenty of fiber. There's data that it decreases polyp formation. Probiotics, I am a fan. I don't know if everybody is, but I'm a fan of probiotics. You know, decrease in bad fat, good protein, not so much sugar. I don't know if there's anything specific to the digestive system. I think small, frequent meals are a lot better than big, heavy meals. Not eating right before you go to bed. Those are all basic things. So we're back in the rectum again. So again, these are those valves. 1, 2, 3. So anything here and below is basically rectum, and above that is colon. So I think most of the time it's just eating smart. Anything you do for your normal life, I think, will be good for digestive health. I just am a little bit bigger believer in probiotics than maybe others are. So what I'm going to do now is I'm going to turn the scope on itself. So I have retroflexed, and so that big thing sitting at about maybe, I don't know, 4 o'clock is a large internal hemorrhoid, and you can see, I can see the number on the scope. So I basically flip the scope on itself. So that's retroflexion. We often do an anoscopy or an exam with a little scope to look at that area specifically, and you can also see it coming out. But you can see there it is right there at about 9 o'clock, that same one. But it's not always evident. That's why retroflexion is important also. And these are just little blood vessels going through the rectum. There's nothing abnormal about those. And those are hemorrhoids that I showed you. And that, ladies and gentlemen, concludes this colonoscopy.
We'd like to thank everybody for joining us today for Community Health Network's first live colonoscopy. I want to make sure that if you're interested in scheduling your colonoscopy today, call 1-800-777-775, or to make an appointment with one of our MD Anderson Cancer Network certified physicians for colon cancer, call 317-621-4321, or you can also go to the website ecommunity.com/colon cancer. Thank you again, everyone, for joining us today.